Good afternoon and a warm welcome to our audience and our expert panelists. On the occasion of World Heart Day, we have all gathered here to understand the process and know how more to care about the cardiac issues at Jehangir Hospital. I'm Dr. Farzana Mulla, neuropsychologist and host for today's session. Why taking care of our heart is so important in today's times. Urbanization has led to changes in the way we live our lives today. Working more, working faster, trying to balance the work-life factor, stress, is what lives in cities has become synonymous with. It is no surprise that our heart is suffering. Chronic heart disease in cities and in the country has increased many folds. Risk factors for chronic heart diseases such as diabetes, hypertension, cholesterol, blood pressure, smoking, they have all increased tremendously and are the primary factors because of the lifestyle that we are leading. Hence, all these conditions are also called lifestyle diseases. Also, coronary heart disease is much more aggressive in India than compared to the rest of the world. Young population is getting affected more and more. Multiple blockages are being seen in a single Asian Indian patient as compared to the Western population. So let us listen to our team of experts here on the latest knowledge in managing our heart health. Let me take this opportunity to welcome and introduce our panelists. We have with us Dr. J.S. Dugal, Interventional Cardiologist with 42 years of experience. We have also with us Dr. Ajit Mehta, Interventional Cardiologist with over 17 years of experience. Dr. Soumya Chandrashekar, Consultant Accident and Emergency Services. Ms. Arya Kulkarni, Chief of Nursing Services. Dr. Radhika Patil, Senior Physiotherapist. And Ms. Richa Shukla, Senior Clinical Nutritionist. So without much ado, let me start with the first question. So Dr. Soumya Chandrashekar, this is for you. When a cardiac patient, first comes to the emergency department, code cardiac is raised at the hospital. Can you elaborate on the code cardiac?
Sure. Good afternoon to everyone. Wishing all of you a very happy World Heart Day. So to come to the question of code cardiac. Now, this is a unique emergency response system that we've devised where any patient who comes to our emergency department with an acute ST elevation myocardial infarction, which is in simple words a heart attack, when a patient presents with these symptoms to our emergency, we announce a code, which is known as code cardiac. So after initial assessment of the patient for signs and symptoms, and after an ECG, we are able to tell if the patient has this sort of an ST elevation MI. And in this case, we activate a code cardiac on the public announcement system. This helps to alert our cardiologists, our catheterization laboratory, as well as our admissions team, who help to hasten the process of admission of the patient and reduces the time from the door to the angioplasty, which is door to balloon time. We have aimed at door to balloon times of less than 90 minutes, which is as per the international standards. And ours being a PCI capable center, we have successful continuous quality monitoring of this indicator. And we try to ensure that this is kept at less than 90 minutes. By doing so, we've also seen that this helps in reducing major adverse cardiovascular events, also complications like abnormal heart rhythms, like arrhythmias. So I think this is how it helps the patient also for prompt and efficient care.
Thank you.
Thank you.
My next question is also to you, Dr. Chandrashekar. How often do you encounter a patient who suffers a cardiac arrest in emergency room? And how do you recognize or prevent it?
Yeah. So we encounter cardiac emergencies on a daily basis in the emergency room. Now, careful observation and monitoring of the patient in the emergency room prevents a cardiac arrest. So, early treatment of pre-arrest conditions can actually prevent a cardiac arrest. However, in the unfortunate event of a patient suffering a cardiac arrest, we have a team of qualified doctors who are basic and advanced cardiovascular life support trained. So they are able to recognize a cardiac arrest, which is a case where a patient becomes suddenly unresponsive and does not breathe and does not have a carotid pulse. So basically, the heart and lung have stopped. So in this case, the patient will require high quality CPR, which is cardiopulmonary resuscitation, where we give chest compressions as well as ventilation, which is breaths, to try to revive the patient or resuscitate the patient. When there is return of spontaneous circulation, then the patient is taken up for more definitive care in the form of angioplasty or further reperfusion therapy. So this is how we ensure that we recognize as well as prevent a cardiac arrest. And our aims have always been to identify these cardiac emergencies early and triage them appropriately. Yeah. Thank you.
So from the cardiac emergency room, the person eventually will move to an interventional cardiologist. So Dr. J.S. Dugal, this is a question. Can you please elaborate on the complex percutaneous coronary intervention like chronic total occlusion?
A chronic total occlusion, as by the definition, first of all, a patient has been having that problem. It is chronic. By definition, it is about 3 months old. Then total means there is no antegrade flow. Absolutely, the artery is not flowing, and that is known as chronic total occlusion. Now, this chronic total occlusion is the question asked is, what is the benefit of opening a chronic total occlusion? Now, when you open a chronic total occlusion, it decreases the angina, it decreases the arrhythmias, it improves the function of the heart, that is what we call it ejection fraction, and also improves the quality of life. In any cardiac catheterization laboratory, if you do angiography or cardiac catheterization, 1/3 of them will have chronic total occlusion. Besides having an acute problem with the other artery, the total occlusion is present in 1/3 of the patient. So therefore, this has been, earlier these were referred for CABG. Now they can be dealt in cardiac catheterization laboratories successfully with the advancement of technology, available of good hardwares and the wires and balloons that we can open these arteries. And I would like to show you a picture, if possible, of a chronic total occlusion, how it is, and how do we manage this. Can I? Now, this is a patient who has got chronic total occlusion, and it's not working. So this is a chronic total occlusion. Now, this artery, which is a right side artery, which is showing, it is completely occluded and it is filling from the left side. So we study how to open this artery, how long is the duration, how dense is the calcification, tortuosity, and presence of good interventional collateral. Now, this patient had, after doing it, his function improved, his quality of life improved, and you see this is after opening the artery. Now, patient is absolutely fine. This procedure is a long procedure. It took about 6 hours to do it, and the quality of life has improved. Thank you.
My next question to you, Dr. Dugal, is how to treat a calcified artery, including coronary high risk and interventional procedures, cases, and what are the new treatment modalities?
What we having today is what is known as CHIP. CHIP is coronary intervention in high risk interventional procedures, and we have a triad of the patient's clinical factors. We have the anatomy of the angiography and what is his LV function. Generally, the LV function in the high risk is less than 30-35%. there is the anatomy is there is complex lesions, calcified bifurcation, left main artery disease, and as I've discussed, the chronic total occlusion. Plus, the patients are generally aged, more than 80 years we are doing it, chronic renal failure, diabetes, hypertensive, multiple risk factors, previous CABG, bypass surgery. Now, these cases have been now dealt in the cardiac catheterization laboratory with the availability of certain tools which we have today. Earlier, only balloon was available when your artery is calcified, but today we have rotational atherectomy, and we also have another device which is available. It is known as lithotripsy. Here we, because of the these ultrasound waves and the waves can basically calcified arteries are opened by having multiple breaks in the artery, and therefore then you can deploy a stent. Because if you cannot deploy a stent, the artery will not open and the long-term results are not good. So I'll also show you an image of a calcified artery and how it is being done today. Now, this is how the calcified artery looks. The upper one is the image of a calcified artery. You can see a dense calcium in the vessel. The lower image is we have imaging system. We have an intravascular ultrasound. We have optical coherence tomography, which can show calcification. Now, these calcification are resistant to balloon dilatation, and therefore we have newer tools. Now, this is the lithotripsy, which is known as shock wave coronary intravascular lithotripsy. It generates certain ultrasound generation and which opens the artery. Now this is a patient which shows a dense calcification. You can see how dense is the artery. You can looks like a calcified. Now this artery was opened with a dual mode. That means it had to go for rotational atherectomy. This is a rotational. It's a bar with diamond chips on it, rotating at a high speed. And this is subsequently, even with the bar, it did not open, and the lithotripsy had to be done distally. And this artery, after stenting, you see the result. So these are the cases which can be done today, which was not possible earlier with the availability of techniques and which we have. Thank you.
Dr. Ajit Mehta, also our interventional cardiologist. What are the new imaging techniques in coronary interventions and coronary physiology? And what's its significance in today's practice?
Yeah, good afternoon to all of you, and happy World Heart Day to all of you. We have come a long way. The first invention of coronary angioplasty was in 1975. And since then, we have come a long way. We used to do simple angioplasty earlier, and over a period of last 4 decades, we have come and started doing very complex coronary work, as Dr. Dugal has already alluded to. Now, when we started 45 years back, we had simple balloon angioplasty, and now after that we had kind of a bare metal stent, then we had drug-eluting stents, and so on. So now, what's new in the field of interventional cardiology? So when we think about this question, first of all, we must understand there is a limitation of just taking decision based on purely on angiography, because angiography has a lot of limitation. There is an interpersonal variation in giving the report in these patients, especially for the moderate, not very significant coronary artery disease, mild to moderate disease have, some people might find it 40%, some people might find it 60%. So there is a lot of interpersonal variability in this disease. There is a image short shortening and overlapping of the vessel, because you must understand the angiography as a two-dimensional picture. It is not three-dimensional. So you probably can realize it. Can we have the lights down? Yeah. So if you see the same artery, in one of the views, it looks 25% stenosis, because probably we are taken in one particular projection. The other projection, it looks like 75% stenosis. So angiography has got this major limitation. So to overcome this limitation, we always constantly, work towards finding out the better ways to treat this coronary artery disease. And as we know, we in India have got, younger population getting affected. Multiple coronary arteries disease is not a single artery which is affected. Even in younger population at less than 40 years of age, we come across triple vessel coronary artery disease. So whether to address all those blockages or to leave it alone, few which are not really very significant, is a matter of concern here. So to answer this, we have what we call is a fractional flow reserve. It's a simple technique, for us, for lay people to understand, we must understand there is a pressure wire, a Doppler wire. So there is a sensor here beyond the block. So if you pass this wire beyond the block and check the pressure beyond the particular disease segment and check the pressure before that. So it's the comparison of the pressure before the block and after the block. And we have to derive a specific value, what we call is a fractional flow reserve, FFR. And if this value is less than 80, come what may, this artery has a significant blockages. If somebody might still feel it is a 60% blockages or might feel 90% blockages, but if FFR value is less than 80, it is significant. So this is a new modality which has actually given a boon to most of the cardiologists, because when we come across coronary angiography with a diffuse coronary artery disease, we don't know which segment to stent. We probably cannot put a stent the entire length of the artery, 2 or 3 overlapping stents, because the chance of restenosis are going to be much higher in these patients. So I'd like to show you a couple of cases. So this is one of the angio what we have done. The right coronary artery showed significant disease in the proximal portion and distal here also. So we thought whether we had to stent both the segments, but when we did FFR, we realized the FFR down here was 0.5, which was significant. As we said, the value less than 0.8 was significant, and here it was 0.88. So we left this lesion alone and stented only the distal portion of the right coronary artery. So is this second case where LAD had about moderate disease. We thought whether we should stent it or no. We did FFR. FFR showed it was not significant. It was 0.87. We left alone on a medical treatment on this patient. Again, just one more, case what we have done recently. 51 years old diabetic, had atypical angina, positive stress test, angio showed moderate disease in LAD. So this is the proximal LAD. This is the main artery of the heart, which supplies more than 60% of the total blood supply. And if you see, there is a moderate disease in the proximal LAD, but she was a young lady, atypical pain, those stress tests was positive. We thought FFR would definitely give us a good indicator whether we should go ahead and stent it. Without FFR, 90% of the cardiologists probably would have stented this lady. So we did FFR, which was 0.93. We left her alone on cholesterol reducing agent, what we call is a statin, and a blood thinner, aspirin. The follow-up angiography after 1 year showed, in fact, there was a regression of plaque in the proximal LAD. So patient could be managed on only medical therapy more than probably going ahead and doing a stent on this patient. The other, there's some time, right?
Yes, sure. We can.
Sorry. So other things what we have is the IVUS and OCT, what we call is the intravascular imaging. As Dr. Dugal has already said, most of the people are denying going for coronary artery bypass graft surgery, even if they have a significant triple vessel coronary artery disease, calcification, multivessel disease, Lechman disease, bifurcation disease, elderly population who are again having multiple comorbid conditions. They deny going ahead with CABG, and most of the people nowadays come to us saying that can we avoid CABG and do angioplasty. So it's actually huge responsibility on a shoulder of a cardiologist to deliver the results as good as bypass surgery. So when we have to do this, we need to use the latest equipment which have been there, and we have been using it at Jehangir for last 4-5 years and with a very good success rate, and we have been doing very complex work at Jehangir. So what we have been using of lately is what we call is the IVUS and OCT, intravascular ultrasound and optical coherence tomography. In short, for layman people, we go within the artery. We put a small microscopic camera within the artery, see the artery from within. The angiography can tell you the artery only from the outside. We can see the artery only from the outside. But here we get to see the artery from inside. We can see what kind of blockages is that. Is it only the blood clot? Is it the cholesterol deposition? Is it fibrotic? Or it has become hard calcific artery? And depending on the plaque morphology, which is shown on either IVUS or OCT, we can modify or we can prepare the bed well to have a stent deployed and having optimum result after angioplasty. So this is a grayscale image of the intravascular ultrasound. This is how it looks. The ultrasound. I just like to show a couple of quick cases. This is a patient who had was probably undergone CABG for the same disease, and within 3 months he came back with the same problem. He had distal left main, which was tight occlusion. So this is how it helps us. So this patient who had post CABG came back with the same kind of a problem. Within 3 months of bypass surgery, we had to take up this patient for. So, in short, what I would like to tell you here is that, this with the advent of this newer imaging modality, IVUS and OCT, we get to see the artery from within. We can prepare the bed well, and after doing because that is very, very important to prepare the bed well for a good long-term results. We have to make sure that the stent is optimally open. It's not optimally open, and this is how the IVUS images run, and this is how the artery looks from within. This is the lumen. This is the lumen of the artery, and this is the final result. We could give as good as CABG. In fact, it was a post-CABG. We have given a better result to this patient after failure of the coronary artery bypass graft surgery on this patient. And intravascular imaging has helped us in a big way to find out where exactly was the calcification, how did we deal with the calcification. We did rotational atherectomy in this patient, and we made sure that post-stent deployment, the IVUS images showed the stent has been optimally opposed and well expanded stent, and there was no dissection, which are the important parameters from a cardiology perspective. This is the grayscale was the intravascular ultrasound. The colorful images are the optical coherence tomography. So again, a case where a patient who has had already one angioplasty done in past came with again acute coronary syndrome, a lot of calcium. We thought we'll do it under OCT, and we did this case under OCT, where you can see the pullback of OCT, where the lumen was looking good, but there was a lot of calcium around the vessel. And after that, this is the final result after doing complex bifurcation angioplasty left main, and OCT showed there is a good expansion of the stent in this patient. So a couple of images just to make you understand. Probably everybody would realize this. See, this is the vessel wall. Angiographically, the stent would look very well opposed, but if you can see here, this is an undersized stent. If you leave this stent alone like this in a particularly origin of the artery, you are definitely there for kind of a big trouble. So we have to make sure that we go ahead with the larger balloon, oppose this stent to the vessel wall, and give good long-term results. So these are all important things what we need to find out on the OCT. Thank you.
Yeah. Dr. Mehta, the next question is also for you. We commonly hear the terms sudden cardiac death and heart attack. Are the two terms the same?
No, actually, this is a misconception what most of the people have it. Heart attack is not as same as sudden cardiac arrest. If you see, the heart attack is kind of a plumbing problem. It occurs because of the stoppage of the blood supply to the heart. The blockage of the heart artery gives rise to heart attack to the patient. There is a damage to the heart muscle, and they eventually die. The person is, but during most of the time of the heart attack, most of the patients are awake, they are conscious, and may complain signs or symptoms of the heart attack, which generally I think most of the people are aware. They may have pain, discomfort in both arms, shoulder, upper back, neck, jaw pain, shortness of the breath. So basically, most of the time, patients with the heart attack are awake, they are conscious. They can explain the symptoms to the doctor. They can most of the time I would say they reach the hospital, but depending on the kind of or the amount of the myocardium at the geopathy. Sometimes what happens, if it is a small heart attack, probably only small muscle part is involved, and patient may have a mild or intermittent chest pain. But sometimes patient may have a massive heart attack and cannot even make it to the hospital. So this is what is called heart attack. Generally, in a medical term, what we call is a myocardial infarction. As opposed, the sudden cardiac arrest is an electrical problem. So a sudden cardiac arrest is different from heart attack. While heart attack is described as a plumbing problem, sudden cardiac arrest is more of an electrical problem. There is a what we call is a cardiac arrhythmias. It could be bradyarrhythmia or it could be tachyarrhythmias, which leads to sudden cardiac arrest in this patient. And a heart attack could be one of the leading cause of sudden cardiac arrest, but there could be many other causes like congenital abnormality, severe heart failure, electrocution, or drug overdose. The signs of symptoms: there is no sign of life in the patient. If patient has sudden cardiac arrest, there is no sign of a heart beating, there is no signs of pulse or blood pressure being recorded. As a result, there is no the blood cannot be pumped throughout the body, including the brain, and person suddenly passes out, loses consciousness, and appears lifeless, except for abnormal gasping, which, if not treated in time, probably patient may we may lose patient in some time, in 10 to 20 seconds. And importantly, life-saving actions. It is critically important that whoever is near the victim calls the ambulance immediately, checks for the signs of life, and if there are none, probably start CPR. As Dr. Soumya has already alluded, that you must start CPR in this patient. And probably now there is a urge, and probably going on by World Heart Federation, that everybody, even the layman or every civilian, should learn how to give CPR, because it can happen to anybody near us. And probably we do not have those automated defibrillator, but probably if they are available, probably you can use those effectively to give defibrillation shock to the patient, to get them back till the emergency personnel can come in and salvage the patient. Thank you.
So we have had a very lucid explanation about different heart conditions and the different interventions that are used for these heart conditions. We now move to nursing care. Nursing role is vital at our hospital, more so in the code cardiac that is raised at the hospital. So I would like to know from our Chief of Nursing Service, Ms. Arya Kulkarni, that what is the role of nursing staff in emergency cardiac cases?
Thank you, Dr. Farzana. Good afternoon, all. Happy World Heart Day. Yes, I agree, nurses play a vital role. They play the key role in stabilizing patient, and they are integral part of code cardiac program in JH. Nurses, right from ER till the patient gets stabilized and go to home from the ward, they are integral part. From ER, they are the transport nurse in the ambulance, they are triage nurse, they are emergency nurse who monitors the patient effectively, stabilizes patient in ER, prepare the patient from ER and early transportation to cath lab. Here, all my nurses are ACLS trained, and they really able to give effective CPR like Dr. Soumya told. They are there because of that. The cardiac program is very effective, and we are able to reach to the door to balloon time. In cath lab, there are complex cases like Dr. Dugal said, and nurses are effectively able to assist them, and they are able to pre and post monitor after the procedure, which is very much important. In a ward and in a ICU, they are monitoring the patient for the faster recovery, giving a direct care, escalating the problem if any, and they are also helping them in patient and family education and also in rehabilitation program. So here to summarize, So here to summarize, nurses are not only the direct caregiver, but they are also a critical thinker. They are a program monitor, sometimes they are educator, they are administrator, supervisor. They are also a researcher, because lot many is done in code cardiac program. So they plays the different role in different situations, and they are instrumental in faster recovery of the patient. Thank you.
So we have come to know from Ms. Kulkarni the very critical role that nurses play in the comprehensive care of cardiac patients. Moving forward from there, once or after a cardiac procedure has successfully happened, patients and family members have several questions in their mind. Some of these primary questions are: when are we going to go back to work? What quality of life are we going to have? How much I can exercise? What can I do? What can I not do? So this is where the importance and role of the rehabilitation team kicks in. So from a rehabilitation point of view, I would like to ask our senior physiotherapist, Dr. Radhika Patil, can you tell us what are the various techniques for cardiac rehabilitation?
Thank you. Good afternoon, everyone, and happy World Heart Day also from my side. To answer your question, Dr. Farzana, cardiac rehabilitation at Jehangir Hospital begins immediately after any surgery or procedure that is performed. So, in phase one, right from the ICU onwards, we try to prevent complications of surgery, and the aim is to mobilize the patient out of bed as soon as possible. After this is done, by the time of discharge, we try to make sure that the patient is ambulating well and is functionally absolutely independent. When it comes to phase 2, which is about 8 to 10 days after discharge, we take our cardiac rehabilitation into our OPD, and we first perform a submaximal test on the patient to establish the current status of the heart. And based on this test, we basically tailor make an exercise program which fits the exact needs of this patient. The exercise is continuously monitored, and it is, of course, has a backup team. It is continuously increasing in intensity because the aim is to improve the fitness and endurance as well as strength of the heart. So in that way, we are constantly counseling the patient to dispel any fears that they might have. We hold their hands to return to work, help them to get back to any regular physical activity or hobbies that they used to have before, and of course answer a whole lot of questions that crop up every time during this period. That's about our cardiac rehab program.
Right. Also, Dr. Patil, can you tell us what type of exercises or physical activity is beneficial for a heart patient?
Okay. So, for a healthy heart, I'd like to emphasize 4 principles. The first principle is that one should be active throughout the day. So, there are several opportunities that one has to seize to be active. So walk whenever possible, take the stairs instead of the lift, play with your children, and so many other ways that you can be active. The second principle is to sit less. So we always encourage our patients to, no matter how much they exercise or even if they're regular exercisers, we keep telling them to sit less and reduce their sedentary time, because that is a risk factor which is independent of any inactivity. It is independent risk factor for heart disease. The third principle is to exercise, of course. So we always advise our patients to indulge in moderate intensity aerobic type of exercise at least 5 times in a week, if not every day. Apart from this, it's always good to concentrate on your strength, balance, and flexibility at least twice a week. So these exercises should be done for 30 minutes at least every day, if not every day, 5 times a week. The last principle that I'd also like to emphasize on is that people need to get enough sleep, because your body needs to recuperate and to get back or come back from the stresses that we place on it every day, right? So speaking of stresses, now I'm going to come back and ask you a question, Dr. Farzana, that sometimes when we counsel a patient, we tell them what to do, but we don't always see that they are able to do it or follow the regime that we give them. So is there anything that psychology can help us to work better and rehabilitate these patients better?
Yeah. Thank you very much for that question, Dr. Patil. In fact, psychology plays a very critical, but sometimes I see a very under recognized role in a cardiac rehabilitation program. There are a number of factors why psychology is needed. When people have to go through a chronic disease, because heart disease is a chronic disease, and the treatment and the changes that one needs to bring about in one's life in order to maintain a healthy lifestyle is also very chronic and long lasting. So, behavior change is a complex and a slow process. People are used to particular lifestyles that has contributed them towards getting coronary heart disease. In most of the cases, I would say, particularly young people and which have had a high amount of risk factors like diabetes, hypertension. So, stress plays a very important factor here as well. So, when we are attempting to change people's behavior, we have to look at a number of factors. What are their belief systems? So, people have a lot of health cognitions about them. Okay, these conditions I have landed up because they are not in my control. Okay, something happened, or my environment is very stressful, or somebody else needs to look after my diet, not me, or I can't change, or people are used to very unhealthy patterns like sleeping less, sleeping late, unhealthy coping strategies like drinking a lot of alcohol. So, if one has to work towards changing these habits, then psychology plays a very important role. Helping people identify their health cognitions which are not appropriate or which are leading to unhealthy lifestyles, helping people identify their maladaptive behavior patterns. Okay, so a lot of people would say, oh, but everybody else is having so much of fast food and drinking so much, so why me? Okay, well, why did I get it? I'm not doing as much as others. So addressing these sort of belief systems, these sort of unhealthy thinking patterns is very important if we have to produce any changes in people's behaviors in a longer term. And next is long term adherence. So, if you're just going to use fear factor as a way to make people adhere to medicines or adhere to changes in their either diet or physical activity or any other changes, reducing their smoking or alcohol, it's not very long lasting. So, if you help people, okay, think in terms of a positive lifestyle, a healthy lifestyle, the benefits that they're going to derive out of this in the long term and how they can sustain this, then it is where psychology will come in and play an important role. And we have very good therapies like mindfulness based cognitive behavior therapy, acceptance and commitment therapy, which work with people's health related behaviors and cognitions and bring about changes in them. Right. So this also brings me. Right. Yes. So we have with us Dr. Harshiel Joshi. He's our cardiac anesthetist. And my next question to you is, what is the role of cardiac anesthetist in this process?
The anesthesiologist is a branch which mostly hidden behind the curtains. Mostly cardiologist and cardiac surgeon deal with the patient and their problems. But we play a very important part in the team of the cardiology. When the cardiac surgeon or cardiologist are busy in putting stents or doing surgery, okay, they are only concerned about their own procedure. At that time, we anesthesiologists look after the patient as a whole. So it's a proverb that cardiologist looks through the hole and we patient looks as a whole. Okay, so at that time we maintain an airway. Suppose there is any emergency condition and patient BP is dropping, cardiologist or another who is doing the procedure can't do everything at their own. So at that time we maintain the patient's vitals, their oxygenations, their blood pressure, and if any arrhythmia is happening, we control them pharmacologically or mechanically. So we mostly stay behind the curtain, but we play an important role in maintaining the patients vitally throughout the procedure. So we start taking part in the patient treatment from pre-operatively We take care of the patients, manage the patient, and make them vitally stable. And then in the post procedure, when they are in the ICU or in the ward, at that time also we look after them and taking care of their vitals and everything. So that is the role of cardiac anesthetist.
So, going back to rehabilitation again, dietary advice and intervention is so important in cardiac rehabilitation. We have with us senior clinical nutritionist Ms. Richa Shukla. Can you tell us what nutrition and diet one should follow with respect to cardiac care?
Yes, absolutely. Thank you. Pardon me for my sore throat. First of all, good afternoon, everybody. And happy World Heart Day to all of you, all my panelists and all my viewers. It is extremely important to understand the relation between a healthy diet, balanced diet, and your heart condition. It is directly proportional of what food choices you make and what's your heart's condition. And certain foods that you limit or certain foods that you increase the consumption can make a lot of changes. So maybe a few tips in the dietary changes that one can do could be, first of all, control your portion sizes. That's extremely important. And the basic thing that we can do at home is probably have smaller bowls, smaller plates. Whatever are the high caloric foods have to be consumed in a controlled manner. That is also extremely important. The next tip could be increasing the consumption of fruits and vegetables. Now, this is extremely important because fruits and vegetables are not only very high rich sources of vitamins and minerals and fiber also, which is again extremely important for lowering your cholesterol lipids, but are also low in calories. And when one increases the portion of fruits and vegetables, by default, you cut down on packaged foods or the other high calorie foods, which is again very, very important. So increase the portion sizes of fruits and vegetables. Next is to include more of whole grains rather than including refined flour in the form of refined flour, maida or white bread. Rather go for something like whole grain, whether it is whole wheat, whether it is oats, whether it is barley or quinoa, any other options. They are fine, but they are better suited. Again, the micronutrient content and the fiber content of all these whole grains is higher, which definitely has substances which help in preventing cardiovascular diseases. Next is also to remember to limit 3 S's basically. One is salt, one stands for sugar, and the other stands for saturated fats. This I keep reiterating to all my clients. Why? Because sugar again is simple empty calories that you land up eating. So you can definitely include a little bit of sugar in your diet, but you need to limit on the portion sizes. Next is salt. Salt is also extremely important because it is directly related to your blood pressure. So try to limit on the foods which are higher in sodium content like sauces, condiments, different dips that you have. Rather opt for something homemade like homemade yogurt, low fat sources, etc. And when you do that, remember to read the labels. Reading labels is extremely important for a consumer because nowadays you have everything available in the market. So read the labels, whether how much is the sodium or salt content in the packaged food. Go for something which is no added salt, low sodium kind of a label food rather than opting for the other foods. That's important. Maybe a daily intake of 1 teaspoon of salt is fine for the patients. And also the third S, which stands for the saturated fats. Generally, red meats, hydrogenated fats, shortenings, these kind of fats like butter, margarine to be in the simple words, should be limited. We should be regulating these. Try to avoid trans fat food sources. Again, trans fat is extremely harmful for your heart. So you should be avoiding packaged foods as much as possible with these trans fats content. Also, you need to remember to try to limit alcohol, which varies from person to person, and we define it for the person or the client coming to us. Next is to remember to choose your protein sources very carefully. So when you choose your protein sources, choose from low-fat protein sources. Especially for non-vegetarian, you can include lean meat, fish, eggs, poultry, etc., are great sources. You could include these. But for vegetarians, you could include dairy sources, soy products are excellent, whole legumes are excellent because they're all very, very high in fiber as well. So these kind of plant-based food sources should be included. And last but not the least is plan your meal way ahead. Choose your meals and make your menu prior itself so that you can buy your grocery and fruits and vegetables for the planned menu that you have in mind. And you don't end up eating anything that is in front of you. That is extremely important. Think of something which is doable and enjoyable also at the same time so that it is long lasting and you follow these kind of diets. So remember, with planning and these kinds of little substitution or replacements, probably you can bring about a lot of changes and you can eat with your heart in your mind.
Right. Thank you, Ms. Shukla. One more question there for you. So when it comes to preventive and post-operative cardiac care, what are the different services available?
Yeah, extremely. We all have spoken about comprehensively about the treatment plan, including exercises, including cognitive planning for the patients, and diet is also extremely important, especially the preventive approach. We have a lot of preventive measures for especially cardiac care health, and it starts right from our annual health packages or cardiac packages that the patients come for, that we have initial screening and counseling for such patients, and we discuss the diet in detail with the patient and counseling them well enough, understanding what is their intake, daily intake. Plus, we have a lot of patients who get admitted with cardiac symptoms. Right there, we start with the preventive measures of counseling each and every patient. Also, we have a lot of corporate talks, and we have a lot of community session awarenesses which are being conducted for these kind of preventive measures. And we explain and counsel a lot of clients about what are the dietary approaches one should be following. Like I just said, that we start at the very initial phase itself. When the patient gets hospitalized, we have a unique and up-to-date clinical nutrition team at Jehangir Hospital with well-qualified clinical nutritionists, wherein we start the initial screening and assessment of the patient to understand the nutritional status, and if at all the patient is at any risk of malnutrition or any intervention needs to be planned. And post that, we monitor the patient's diet, and even post-operatively, we monitor very closely, of course, in consultation with our doctors and consultants about the diet. And after the discharge, also it doesn't stop, the rehab continues. We have a primary role even in the rehab, cardiac rehab, especially post the discharge. We call the patients in the OPD and we discuss the details of dietary aspects plus its correlation with the cardiovascular risk factors. And we tell them what to eat, what not to eat, how much to eat, and also at what time to eat, to discuss the details of all these dietary aspects. And then we call them for a follow-up, wherein we review their diet, we evaluate them, and we try to see that we can help them as much as possible for them to reach their targeted goals. Again, I like to reiterate that keep your keep your heart to your mind when you make the food choices. Thank you so much. Once again, wishing you all a very happy World Heart Day.
It has been a very enriching and informative afternoon of great information provided by all our panelists. It is very assuring to know that the latest medical technology and the best approaches of rehabilitation in cardiac care has been available at Jehangir Hospital for a long time. And it is being used effectively for the benefit of the population at large. So I would like to, at this juncture, say a big thank you to all our panelists for taking time out of their busy schedule and sharing their knowledge and experience with us. Do your part, take care of your heart is the motto for this week at Jehangir Hospital on the occasion of World Health Day. I would also like to tell the audience that please use this message and this motto and integrate with all aspects of your life so that you are doing everything and anything which is possible to keep your heart healthy and happy. This is all from all of us at Jehangir Hospital. Thank you. Have a good day.